Instruments required for root canal treatment and access cavity preparation are as follows: mouth mirror, probes, tweezers, spoon excavators, a metal scale, high-speed handpiece, key, burrs and diamond abrasives, and root canal files.
This is a video representation of a maxillary anterior teeth access cavity preparation. Before going into the detail of access cavity technique, a review of the lingual crown morphology. In maxillary anterior teeth, the lingual crown morphology has two main features. One will be cingulum, which is a cervical projection. This cingulum is followed by a shallow depression incisally, that will be a lingual fossa. This lingual fossa is bounded mesially by mesial marginal ridge and distally by distal marginal ridge. You are supposed to start your access cavity preparation mesio-distally center of the tooth and cervicular incisally just beneath the cingulum projection. This colored mark area represents the area where you are supposed to start your access cavity preparation. You are supposed to start your access cavity preparation with the round diamond rotary high-speed instrument. Now I have cut off the water supply in this high-speed handpiece so that there will be a better clarity of vision. Okay, but in reality and in your preclinical exercises you will be working under water spray and you are supposed to have a rubber bowl or any container to receive the water supply. You are starting your access cavity preparation with a round high-speed diamond burr held perpendicular to the long axis of the tooth. First you are entering into the enamel. Once you have penetrated the enamel, you are going into the dentine, and once you are into the dentine, you will be able to smell the cut of the dentine. And once you have penetrated the dentine, you will be able to feel a small drop into the pulpal chamber. Once you have felt this drop, now it's time to change your round diamond instrument to a tapering fissure burr. Change the round burr to a tapering fissure burr. And this tapering fissure burr is held parallel to the long axis of the tooth, not perpendicular. Now we are entering into the access cavity preparation, and you are working from inside the cavity to outside so that you are removing the lingual shoulder of the preparation. At the same time you are widening the access cavity so that it forms into a triangular shape with widened base at the incisal portion, and apically it's converging. And you are also giving an incisal bevel so that you are able to get a straight line access. You are removing the lingual shoulder. Once you have finished the preparation, you are supposed to dry the preparation with a 3-way syringe so that you will have a better evaluation of the access cavity preparation done. And this will be the shape of your final access cavity preparation, which should be triangular in shape with apex pointing cervically and widened base of the triangle incisally. And the straight line axis of the access cavity preparation can be evaluated by placing a root canal small size file. And you want to see that your root canal instrument is free from any obstruction in your crown access cavity preparation. This will be your finished access cavity preparation with the straight line axis.
With the unmounted teeth, the root is exposed and the initial estimate can be made by placing the tooth against the edge of a ruler and measuring the length from the incisal edge to root tip. Another method of measuring an unmounted tooth is to place the file against the incisal edge and adjust the stopper on the file until the file length equals the estimated length of the canal from the occlusal landmark to the apex. Check the measurement by inserting the file in the canal. If the file extends beyond the apex, slowly pull it back until it is no longer visible and push the stopper down to mark the length. This will give you the anatomic length of the canal. Place a file in the canal to an estimated length. With the file in the canal, note the occlusal landmark that you will use to establish the length. The landmark must be easy to see. Avoid using the lingual on-incisors if possible, as it can be difficult to see on an angle. Instead, find an incisal edge that you can readily see. The most clinically relevant working length landmark for both clinical cases and mounted teeth is the apical constrictor. Take a radiograph and examine the developed film. You should see the instrument inside the canal. If the tip of the file does not reach the apex, adjust the length of the file or use a longer one and repeat step 2, using the radiograph to estimate how much longer the file should be. If the file is too long, adjust the stopper or use a shorter one and repeat step number 2. When the tip of the file just reaches the apical constrictor, the file length is the anatomic length of the canal. This particular tooth has a measured anatomic length of 25.5 millimeters. The working length of the canal will be measured 1 millimeter short of the radiographic apex of the root. The initial file used to take the diagnostic measurement will be set to the anatomic length, the measurement from the occlusal landmark to the radiographic apex. Other than this anatomic file length, all subsequent file measurements will be set to the working length measurement, the radiographic apex depth minus 1 millimeter. In this example, the anatomic length of the canal is 25.5 millimeters. Therefore, the working length is 25.5 millimeters minus 1 millimeter, or 24.5 millimeters. Document the correct working length and continue with the radicular preparation or cleaning and shaping of the canal. Recall the working length of the canal and the size of the last file used. Step-back shaping will then be complete with the following sequence of file sizes and lengths. 55K, start instrumentation at 23.5 millimeters. 60K, start instrumentation at 22.5 millimeters. 70K at 21.5 millimeters, and 80K at 20.5 millimeters. Note that after 60, the K file increases in increments of 10 rather than 5. Begin with the first shaping file, measured to the working length minus 1 millimeter. In this case, it is the 55K file at 23.5 millimeters. Shape the canal using a combination of reaming and filing actions within the canal, similar to the combination used in cleaning. Again, copious irrigation is important throughout the shaping of the canal walls. In step-back filing, each succeeding file must reach the correct length. If the specified canal length cannot be reached with the corresponding K file size, do not start shaping at the shorter length or force the instrument farther down into the canal. Go back to the previous instrument and continue to shape using filing action until the canal is sufficiently loose enough to accept the succeeding file. Repeat steps 2 through 4 for each successively shorter length until you have reached within 4 to 5 millimeters of the canal orifice. After shaping with the last file, verify that the canal walls are smooth and that there is no blockage from the coronal portion down to the apex. Once shaping is completed, the canal is dried using appropriately sized absorbent paper points. Select the paper point size that best corresponds to the relative size of the canal. In this case, the canal is very large and will require the use of coarse-sized paper points. Using the cotton pliers, remove a single paper point from the package and insert the paper point in the canal up to, but not beyond, the working length. Measurement control for paper points is achieved by grasping the point at the correct measurement, at right angles to the beaks of your cotton pliers. Sterile paper points should be handled with cotton pliers only to prevent infection. Repeat this step until the cotton paper points appear dry when removed from the canal. If paper points continue to appear wet after several placements, the canal may be wet with exudates from an infection, or the apex has been over-instrumented and the paper point is in contact with the root. Recall the last file size used at the working length. In this case, the last file used at 24.5 millimeters was the 50K file. Place this file in the canal and take a radiograph to confirm that the entire length of the canal has been properly shaped. Use this file to also check for patency, to ensure that the principle of resistance form has been met, and the integrity of the apical foramen maintained. The properly shaped canal should have an evenly tapering funnel shape with smooth. Recall the last file used at the working length. In this case, the last file used at 24.5 millimeters was the 50K file. Place this file in the canal and check for canal patency one last time. The properly placed tip should elicit tugback at the apical region when an attempt to remove the file is made. Prepare a mix of root canal cement using the cement powder mixture provided and a few drops of eugenol. Mix a small amount of eugenol with a small amount of powder using the spatula until the mixture is loose and tacky. When pulled with a spatula, the cement should stretch about an inch above the work surface. Continue to add small amounts of powder or eugenol until the desired consistency is attained. When fully mixed, the cement should be smooth and homogeneous in texture, not grainy. When fitting the master gutta percha cone, you must judge two parameters: approximate diameter at the apical constriction, evidenced by tugback or resistance at the apex, and length at the apex of the root canal that you just cleaned, or working length. Both the tugback and working length must be correct. When tugback is evident, there will be resistance to removal and the cone will be engaging in the apical constrictor. If the taper of the canal is too narrow for the gutta percha cone, the cone will not reach the apex. If the apex is over-instrumented, the gutta percha will extend beyond the apex. If the taper of the canal is large enough, it will engage at the apical constrictor. Place the last file to the working length and the last file that you shaped with on the benchtop. Select a gutta percha master cone that reasonably approximates the shape of the prepared canal by estimating a size that lies between these two files. Using cotton pliers, remove a single gutta percha cone from the package and measure the cone to the working length. Remember, sterile gutta percha cones should be handled with cotton pliers only to prevent infection. Place the gutta percha cone in the prepared canal up to the measured working length. If the point binds before reaching the measured length, select a thinner point. If the tip goes to measurement but does not elicit tugback, cut away 1 millimeter from the tip of the cone and try again. Continue to cut away the tip and try the cone again until tugback is achieved at the working length. Remember how much you cut away at the tip. You will have to cut this amount away for each subsequent cone that you use in filling the canal. After cutting away the tip, if tugback is achieved but the length is too short, the cone must be discarded and a new cone must be measured and adjusted to fit the canal. When the tip of the cone binds exactly at the working length and offers resistance to withdrawal or tugback, check the working length once more to verify that the measurement is correct. Remember, both the tugback and working length must be correct. With the gutta percha cone fitted in the canal, take a radiograph to confirm fit of the master cone. Once the master gutta percha cone is fit, the canal is ready to be filled using the lateral condensation technique. Begin by placing the cement into the canal using the last working length file. Cover the file with cement and place it into the canal. Use the file to line the walls of the canal circumferentially, distributing the cement on the walls of the canal evenly, 2 or 3 times. Using the cotton pliers, remove a gutta percha cone from the package and cover it with an even coat of cement. Place the cone in the canal to the working length until tugback is elicited. Extrusional cement may be witnessed with the unmounted teeth. This does not cause a problem. While no cement is irritation-free, once it sets, the body accepts it and no long-term irritation persists. Place a D11 spreader in the canal alongside the cone. Apply pressure apically to push the spreader in as far as possible and spread from side to side. This side-to-side or lateral spreading motion is the basis for the technique name, lateral condensation. The D11 spreader is available in both titanium and stainless steel. The stainless steel spreader may be used for straight canals. For curved canals, the more flexible titanium spreader should be used. Stainless steel finger spreaders may also be used. Remove the spreader and heat the long end Glick No. 1 instrument in the Bunsen burner flame. Place the heated Glick No. 1 in the canal to the floor of the pulp chamber and move the instrument side to side, heating off the protruding gutta percha. If the instrument is not hot enough, some of the gutta percha may be left behind. The instrument should be reheated and the rest of the gutta percha removed. Place the spreader into the canal as far as possible apically and spread from side to side, compressing gutta percha and cement against the walls. Repeat steps 13 through 17 using accessory gutta percha cones until there is no more room in the canal for additional gutta percha. Do not place an accessory cone with a diameter larger than the remaining apical end of the canal. The cone will not fit to the end, and this can create gaps in the filling. When the process is completed, there should be no gutta percha on the floor of the chamber. Gutta percha should be placed in the canal only and should not extend into the pulp chamber. Use cotton to remove any remaining cement from the inside of the chamber. A final X-ray should be taken when the condensation is completed. In the clinic, a final X-ray is taken without the rubber dam in place and with a final or temporary restoration in place on the tooth. Clinically, it is possible to take a radiograph only in a buccolingual direction. However, in the preclinic, X-rays should be taken in both the buccolingual and mesiodistal direction. This will enable